I will start with a new topic. That's a very important topic, which is basically depend on the uh, what is the nutritional status of the patient, which are uh, being going to be for either minimal invasive surgery or major surgery or any intervention. So this is very important topic because if the nutritional status of the patient is not adequate, it led to the lot of complications in the surgery, in the post-operative period or intraoperative period. So basically, this topic is being uh, planned to teach you so that you should know what are the important factors which can affect the basic outcome following surgical procedure or after the surgery. So basically, this is the algorithm is a the diagrammatic representation of the what we want to know about the uh, outcome of after the surgery. Like if the patient is underwent any surgery, there is a not neoendocrine response, then pro-inflammatory cytokine phase, metabolic changes. This all happens when any patient underwent the surgical procedure. Then there is a sort of protein energy loss, and there is a slow recovery, poor wound healing, and increasing infection. So basically, this ladder is related to most of the outcome of the surgical patient after the surgery. Okay, so in this lecture, we will discuss with the some important aspect of the nutritional aspect of the surgical patient. Like start with the nutrition introduction, then enteral nutrition, then parental nutrition. Okay, and after that, another interesting topic is recent guidelines for the surgical patient, like ERAS protocol. We have been taught to you. Okay, this is not written here, but I will teach you. Okay. So to start with the introduction, we start with the definition, the cause of the nutritional deficiency and nutritional status and assessment and support. So why it is very important to know the nutritional deficiency. They are basically these are the obstacles which delay the recovery. Uh, so what are these obstacles? Basically, you should know. Okay, apart from nutrition, there are other obstacles like preoperative organ dysfunctions, any surgical stress, patient in the catabolic phase, pain, post-operative nausea, vomiting, fluid excess, semi-starvation, immobilization, or surgical traditions or culture that afraid include that like neural blockade, pharmacological interventions, fluid temperature management. These are all other apart from nutritional components. These are other obstacles which can delay the recovery in the post-operative period. So basically, we should learn here is the what is the basic problem which arises if the patient is not nutritionally uh, fit for the surgery. So definition wise, the nutrition is there are a lot of other definitions. So basically, but here is basic and simple definition is the nutrition is taking in and metabolism of the nutrients by an organism so that life is maintained and growth can take place. So this is a simple and elaborated definition of the nutrition. So I am just again repeating it. So nutrition is the taking in and metabolism of the nutrients by an organism so that life is maintained and growth can take place. Okay. And along with this, the nutritional definition, there is the common terminology which are now associated with the nutrition, like malnutrition. Malnutrition is basically when the patient or any individual which is not properly nourished. So this suffering from the malnutrition. The malnutrition is a disorder of nutrition or a wasting condition resulting from energy and protein deficiency, and sometimes with vitamin and trace element deficiency as well. So basically, definition wise, malnutrition, it is contradictory to the nutritional. The malnutrition is a disorder of nutrition or wasting condition resulting from energy and protein deficiency, sometime with uh, sometime with the uh, uh, vitamin and trace element deficiency as well. Okay, right. So here the what are the various types of the malnutrition? So here overnutrition is also included in the this interesting thing. This overnutrition is also included in the malnutrition category of the malnutrition. Okay, so obesity as uh, defined by the body mass index is more than 30. Okay, excuse me. हेलो क्लास चल रहा है मैं बाद में बात करता हूँ आपसे हाँ बाद मैं क्लास चल रहा है बात बात so basically the overnutrition is definition wise the obesity it is the obesity called overnutrition also the obesity is basically because of the overnutrition and defined by the if the BMI is more than 30 then it is the called as the overnutrition and the undernutrition is the patient is undernutrition malnutrition in the category of malnutrition there is a so malnutrition can be either the overnutrition or undernutrition. So overnutrition if the BMI is more than 30 and then the undernutrition is it is less than 22. Okay, so undernutrition can be a caloric or non-caloric. Caloric means the like the where you can find the deficiency in the uh, inadequate protein and calorie intake, typically caused by the illness like illness-induced anorexia. So marasmus is one of the clinical condition which is associated with the caloric undernutrition. So I'm again repeating it. The marasmus it is characterized by the inadequate protein and caloric intake, typically caused by illness-induced anorexia. Like if a patient is for a longer period of time become anorexic where uh, we are not giving the sufficient nutrition in the form of nutritional support in the form of enteral nutrition or parenteral nutrition the patient will go into the this marasmus like condition so there is a inadequate protein and calorie intake so and it is marked by loss characterized by the loss in weight and body fat and skeletal muscle mass. So both there is the inadequate protein intake and calorie intake which can lead to the loss in weight, fat and skeletal muscle mass. So overall the patient loses the weight. Okay. And there the visceral protein stores, but the visceral protein stores are remain normal. So visceral protein stores are basically inside the viscera. Okay, like in the liver, in the on the bowel. Okay, so visceral protein stores they are remain maintained, but the overall loss in body fat and the skeletal muscle mass, the protein which make the muscle mass, so skeletal muscle mass will decrease. But the visceral here interesting thing is that the visceral protein store is remaining normal. Okay. And then second category is the non-caloric. Non-caloric or circle is the catabolic protein loss. Okay, the hypoalbuminia and generalized edema develop prolonged starvation or severe stress, leading to depletion of visceral protein store and impaired immune system. So non-caloric category is the kwashiorkor. Kwashiorkor is the catabolic protein loss. Catabolic protein loss. Here is the in the kwashiorkor you will not find the caloric intake is decreases. Here basically the problem is with the catabolic protein loss. Protein loss is more as compared to the marasmus. So hypoalbuminia and generalized edema develop with prolonged starvation or severe stress. Severe stress condition will lead to the severe stress, severe catabolic failure, leading to the depletion of even visceral protein store and impaired immune system also. So this is very dreaded situation. Kwashiorkor is a dreaded situation where you find the even the loss of the visceral protein store and also the immune system is the impaired. So as compared to marasmus, the Kwashiorkor is the there is severe protein loss is there. Even catabolic fever will even lead to the generalized edema develop with and the hyperlipidemia. Then uh, importance of nutrition in surgical patient. Basically, the surgical procedures which causes this patient to go into malnutrition because quickly, often before treatment is realized. So optimization is very important. So that concept led to the optimization of the patient, surgical patient who are being planned for the surgery or who is going to underwent major surgical procedure or even a minor surgical. Like today, in the era of this minimal invasive surgery, this the importance of malnutrition is quite reduced to the limited procedures, where you find that the long hour surgeries or the major open surgeries, the malnutrition is very characteristic. So, but in the minimal invasive surgery, the malnutrition is not very noticed because in the there is a it, in post-operative rehabilitation period, we get the easy recovery after the minimal invasive. But in the major surgeries, certainly we get the malnutrition. So, importance of surgical nutrition is very important. Uh, so basically, it is the nutritional deficiency is often related to the surgical procedure. Okay, so if the major surgeries like bowel surgeries, cardiac surgeries, thoracic surgeries, uh, orthopedic surgeries, they are very important having the role of the nutritional support in this patient. So and also it said that there is evidence that patients with severe protein depletion have greater incidence of post-operative complications. Okay, so apart from it, the patient uh, of the severe protein depletion, which have the greater incidence of post-operative complications. The surgical stress, apart from the protein depletion, the surgical stress like pain uh, and salt food detection, immune dysfunction, and ILS for a longer duration, impaired pulmonary function, increased cardiac demand, hypercoagulability state, and sleep disturbances, fatiguability. All these related to the post-operative complication like pneumonia, wound infection, and prolonged hospitality. So apart from protein depletion, the surgical malnourished patient, the other factors are also responsible for the development of the complication. But the surgical nutrition is certainly a definitive factor where we can have some uh, advantage for correction if the patient is deficient. But and also other factors like if the post-operative pain or pain it is relieved, it ultimately led to the decrease in inflammatory phase and also catabolic phase. So surgical recovery is good. And also the impaired pulmonary function and increased cardiac demand happen if the pre-operative optimization has to be done properly. That's why the role of the uh, this it is basically said that the surgical nutrition is not basically the where we have role of the surgeon only. It's the multimodal multimodality uh, 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 approach where we should have the to optimize the patient for surgery. Okay, so there are other groups of the people which are basically involved like anesthetics, uh, uh, then uh, then dietitians, then trained staff. They are being important, having important role in pre-operative identification of the what is the status of the nutritional status, and then where is the deficiency where it should correct and reduce the post-operative. So ultimate goal is to reduce the post-operative complications so that patient morbidity and mortality should decreases up to the level and patient to reduce the prolonged hospital stay and easy recovery of the patient. So basically the multimodal approach is there for uh, the in the correction of the nutritional and also to identify the other risk factors associated with the uh, uh, surgical procedures, so to minimize the post-operative complications. So basically, the prehabilitation is one of the important factor. That's why it is rehabilitation where we find a lot of other people which are involved in this management of this nutritional aspect of the patient, either going for the surgery or going for the any intervention. So basically, to understand the basic uh, body physiological status of the uh, of an individual. So like this can see the if a 70 kg male is there, okay, so the this is the fat free mass. So approximately uh, 20% is the body fat, which is rest other 80% include the fat free mass that is comprises by the protein and then body fluid, then some sort of minerals which are being found in the uh, protein and extracellular body tissues. So that is the fat-free mass, which is very important. Okay, that's very important, and it's called the lean body mass because this is the fat which is not included in the. This is very important for the nutritional uh, assessment of the patient, that how much of the lean body mass is there. Lean body mass index, which is basically calculated in the lean body mass index, because that has to be built properly to prevent the patients who are undergoing for the major surgeries or surgical interventions to prevent any post-operative. So we should focus on these things. Okay, that's very important. That's why the, apart from protein, the fluid and salt of the salt intake of the body and output, input and output monitoring is very important. So basically, if you calculate it, that the fat is here is a very less amount, that approximately 20, approximately in an adult patient, it fat accounts for only 20 to 25%, and then rest of this protein and the extracellular intracellular fluid. So how to calculate the basically the to energy requirement? Energy requirement, because it daily we have to calculate the energy requirement, which what amount of the caloric intake has to be given to the patient, and protein requirement has also be calculated. So basically here we should know the to calculate it, the 1 gram of the carbohydrate almost provides the 3.4 kilocalorie. So carbohydrate, as you should know, the during the source of the carbohydrate are basically uh, like we should adequately provide the source of the carbohydrate, which provide the approximately per gram there are 3.4 kilocalorie has to be uh, generated by 1 gram of the carbohydrate. Likewise, the fat provides the 1 gram of the fat provides the 9 kilocalorie, and 1 gram of protein provides the 4 kilocalorie. So average adult on an average usually require the 30 to 35 kilocalorie per kg per day. Okay. So if a 70 kg person is there, like 20 kg person is there, the daily caloric requirement is almost 2100 kilocalorie per day. That's very important parameter because caloric intake is as equal as important as the protein intake. Okay, so caloric intake has to be calculated by the how much amount of the carbohydrate, how much amount of the fat, and how much amount of the protein has to be given. Okay, okay. So basically, during unstressed metabolism or starvation period, like if the pre-operative starvation, usually we ask the patient for to 1 day before pre-operative to be like light diet or liquid diet. So that's usually being under calculated in the term of starvation period, unstressed metabolism. Like carbohydrate stores during the unstressed metabolism or starvation period, the carbohydrate is stored are basically exhausted in 24 hours after overnight fasting. Okay, so if patient is remain in the fasting state for 24 hours, the carbohydrate stores are completely exhausted or become less goes down. And during first after that 24 hour, 48 to 74 hours of starvation, caloric needs are basically the metabolism is taken care by the fat and protein. So after the this period is over, where the carbohydrate stores are replenished, depleted, the then the body's caloric requirement is met by the fat and protein digestion. Okay, so basically before 24 hours, it's the carbohydrate, and after 24 hours, between 48 to 70 hours, this is met by the digestion of the fat and protein. And the protein breakdown of skeletal and visceral muscle, which is converted to glucose via hepatic gluconeogenesis. So protein metabolism occurs. Uh, basically proteins of the skeleton and visceral muscles, which is converted to glucose via hepatic gluconeogenesis. And brain has obligate glucose requirement. So rest is utilized by the RBC and leukocytes. So brain has obligate glucose requirement, and rest is utilized by the. So brain will should know that the it is in brain's neurons requires the almost important to know that it is obligate glucose requirement is it is basically the uh, characteristic feature of the neurons. Okay, so and the rest of the glucose which has been metabolized from the carbohydrate utilized by the RBC and leukocytes. So it is important to maintain the adequate glucose blood level in the body so that brain activity should be within a normal limit. And after approximately 10 days, brain adapt to use fatty acids, keto acids as energy, which is, has a protein sparing effect. So if after the long hour of the starvation, uh, this brain cells, this neurons, uh, it, after the depletion of this glucose, uh, the fatty acids being utilized because of the unavailability of the glucose. The fatty acids utilize as energy source. Okay, so which has a protein sparing effect. The rest of means the protein metabolism is slower after this period. Okay, so one important thing that basically uh, uh, in the trauma and the following in the major catabolic phases like trauma, major surgeries, and sepsis, uh, there are basically the pathophysiological response to the catabolic phase underwent basically undergo progress into three phases. Like initially there is a catabolic phase, then early anabolic phase, and the late anabolic phase. So it is basically noticed in trauma, major surgery, and sepsis. Uh, Sepsis in the form of either a generalized sepsis or localized sepsis. Okay, so basically the whole of the pathophysiological changes uh, run into the three phases: that catabolic phase, early anabolic phase, and late anabolic phase. The early anabolic phase we can call it as a corticoid withdrawal phase also. Okay, so catabolic phase usually the first phase, that is catabolic phase, where you find the metabolic demand usually dramatically increased. As you notice that the increased carbohydrate digestion is there, metabolic in the first after three, it's just immediately after the surgery the catabolic phase is there. So metabolic demands dramatically increases, and there is significant increase in the excretion of nitrogen secondary to protein depletion. Okay, so we noticed that there is a because of the initial period, the metabolic demands, there is increased metabolic demands, in the early catabolic phase, and it significantly also increases the urinary excretion of the nitrogen and secondary to protein depletion. And then elevated serum level of glucagon, glucocorticoids, and catecholamines with decreased insulin secretion. So elevated serum level of, there is, you will notice that in the catabolic phase there are significant changes in the body physiology. Okay, so there is increase in the urinary excretion of the nitrogen secondary to protein depletion, and also elevated serum level of the glucagon, glucocorticoids, and catecholamines with decreased insulin secretion. We should know the in the early catabolic changes which happens. In the catabolic phase, the first phase of following the major surgery or trauma or any sepsis, the localized sepsis, the in the catabolic phase, the metabolic demand usually increases, and there is a significant increase in the urinary excretion of the nitrogen, which is secondary to the protein depletion. And there is also the elevated level of the serum glucagon, glucocorticoids, catecholamines, and also with decreased insulin secretion over there. Okay. So after catabolic phase, there is the early anabolic phase, and then following that the late anabolic phase. So early anabolic phases usually it's that's basically it ranges from the several days to several weeks. Okay, after the catabolic phase is over, the early anabolic phase came into the picture. Okay, so this is also called the corticoid withdrawal phase, where the catecholamines and the stress induced hormone, these are become decreases in the blood in the body, and the anabolic phases start. So early anabolic phases after the catabolic phase, the early anabolic phase started, where find the it basically it lasts from several days to several weeks, even up to the several months also. So depend on the ability of the patient to assimilate the nutrition, and also depend on the what amount of the protein, or what up to the what extent of the protein is being depleted or exhausted. Okay, so early anabolic phases basically it lasts from the days to several weeks to months, and also depend on the ability of the patient to obtain the uh, proper nutrition, and up to the what amount of the proteins which are being stored from the skeletal muscle or visceral protein being depleted. So, and there is a positive nitrogen balance, because here in the early anabolic phase we start feeding the patient, we start weaning of the patient weaning is started in this phase. So there is a positive nitrogen balance always, and there is a rapid progressive gain in weight and muscular strength. Okay, so early anabolic phase basically after the period of the catabolic phase is over and the patient is being start weaning, and there is a positive nitrogen balance, and there is a rapid progressive gain in weight and muscular. Then the and also skeletal muscle become because of the protein replacement. The skeletal muscle become the replacement in the uh, loss which occur in the catabolic phase. So muscular strength will be increased, and the gain in the muscular the hypertrophy and both the hyperplasia, which led to the increase in the muscular strength. So, and then late anabolic phase, then following early anabolic phase, this period is over. The late anabolic phase, the final stage of the, if you continue the weaning and the nutritional support, the final stage of the recovery, this lasts for several weeks up to the month. Okay, and the hair adipose stores are basically replenished gradually, and weight gain is much slower, because it post tissue where the fats are being stored, it will take quite long time to gain the fat. So basically, the late anabolic phase, the recovery is it lasts up to the in 1 week to the up to many months. Okay, and here you find the weight gain is quite low. So again, this diagram which we seen in the initial the first slide. Okay, so I am again repeating it, the importance of the nutrition uh, to slow the recovery, poor wound healing, and creating. Apart from the nutrition, there are other factors which we discussed. Okay, uh, to overcome this slow recovery, poor wound healing, and increased infection. The other factors like organ dysfunction, surgical stress, and then pain. Okay, fluid access, and then all these factors that which led to the apart from the nutritional support, nutritional insufficiency that can lead to the slow recovery, poor wound healing, and case infection rate. Okay, so basically this the pathological phenomena which occur even in any surgical procedure, major surgical procedure. Uh, okay, either in the uh, uh, gastro-surgical procedure, then the cardiac surgical procedure, orthopedic surgical procedure, or even after the minor procedures, this some sort of this case. But during the minimal invasive procedures, they certainly will not find this nowadays this sort of ladder. Okay, so basically this is really limited up to the major surgical procedure, and the procedure related to the long starvation period and other complication if other other sort of apart from the nutritional support other deficiencies are noticed. So, so here you see the changes in body weight that occur in serious sepsis after uncomplicated surgery and total starvation. Okay, so total starvation can happen in up to the any sort of uncomplicated surgery. Okay, so here see the certainly the weight gain which occur even of the sepsis and multi-organ failure. Okay, weight gain there is but in uncomplicated major surgery, there is certainly the weight loss is there, and because of the starvation period, there is a weight loss is there. But there is a weight gain because of the fluid retention and sepsis. All these things led to the sepsis and multi-organ failure. So basically, these phases are related to the how much amount of the uh, sepsis is being encountered. So basically, the patient with severe sepsis, they underwent the weight gain because of the retention of the body fluid and all. And the patient in the shock, the multi-organ failure is there. The patient might gain the weight. Okay, and but in the uncomplicated, certainly find. But it is very interesting that there is an uncomplicated major surgery. You certainly find the loss of weight, and it is equal to the period of starvation. Okay, so this is a very interesting diagram. You can see the after a long immobilization or starvation period, this you can see this ultimately led to the catabolic phase. Okay, so the immobilization and starvation both it led to the catabolic phase, and then also the after the catabolic phase, the anabolic phase is started. Okay, so you can see the wound infection. There is a large wound. Then patient also have the hypothermia, like as in a trauma patient, then hypotension because of the severe loss of the blood or the uh, fluid, body fluid, and then the patient having also the pain. If the pain is there, the patient undergoing the catabolic phase, and there is the basically the adenosympathetic activation and cytokine release. The inflammatory pro-inflammatory phase is there. We'll find the in the form of pyrexia, the acute phase response, like systemic inflammatory response syndrome. The insulin resistance is there. Okay, then febrile substrate, febrile exofebrile substrate cycling, which led to the anaerobic metabolism, then muscle protein degradation, and also this all these phenomena, if apart from the immobilization, starvation period, if this complication is prevailing over there, the catabolic phases will be prolonged, and the anabolic phase will be the negative on the negative side. Okay, so this ultimately led to the catabolic phase, and the patient undergoing the malnutrition. The poor wound healing is obviously certainly and that led to the outcome, the poor outcome of the patient after the surgical procedure, major surgical procedure. Okay, so basically, the factors which exacerbate the metabolic response to surgical injury are basically, I'm just enumerating it. Metabolic response will increase after the wound infection, after the hypothermia, hypertension, and pain. And this ultimately led to the immunosynthetic activation and cytokine cascade. The patient ultimately, the characteristic features will find the pyrexia, the acute phase response is there, insulin resistance is there, futile substrate cycling, muscle protein degradation. Okay. So then assessment of the nutritional status. Assessment of the nutritional status is basically find that weight loss is an obvious indicator. Okay, so to decrease the complication rate uh, in the surgical post-surgical period, uh, we have to assess the nutritional status of the patient, because every time the patient underwent surgery, there sort of some sort of nutritional deficiency could be encountered later on. So that's the better to preoperative evaluation is important in this patient to reduce the surgical complication. So that's being started with the assessment of the nutritional status. Okay, so at assessment of the nutritional status, basically is there are 4 or 5 important points. You should know the weight loss is basically an obvious indicator. If there is weight loss, is there, the patient is there. This obviously is the one of the important parameter indicator of the nutritional status. Then dietary history. Dietary history, a patient is taking adequate amount of protein is there, carbohydrate or fat, and oral intake of the fluid and electrolytes, uh, and the green vegetables, all these things. The dietary history is important, because this is then this came to the role of the dietitian, which play an important role in assessment of the nutritional status of the patient and the proper rehabilitation and pre-rehabilitation and counseling regarding the dietary. Right. So the more than 10% of unintentional weight loss is in the 6 month, it is it is called the patient undergoing the significant weight loss. The more than 10% of the unintentional weight loss. Unintentional means the sometimes there is a patient easily intentional weight loss occur because a person want to lose the weight. Okay, that's but basically this is the unintentional weight loss. Means after a proper and normal diet, there is even there is a weight loss which occur in the 6 month, there is a 10% weight loss. That's called a significant weight loss, or 5% loss in 1 month, or there is a 5% loss, another 5% loss in 1 month. Okay, that's important parameter. Then anorexia, the persistent nausea, vomiting, diarrhea, as we discussed in previous slide. This ultimately decreases the nutritional condition of the patient, like anorexia, persistent nausea, vomiting, diarrhea, and malaise. Then loss of subcutaneous fat, muscle wasting, edema, ascites. Loss of subcutaneous fat, muscle wasting, edema, and presence of ascites. This is usually also important tool for the assessment of nutritional fat, nutritional status of the. So I'm just again repeating is that weight loss in the form significant weight loss, more than 10% weight loss, unintentional weight loss, and 6% 5% loss in 1 year. And that's being better calculated by the dietitian has important role over there. And then anorexia, that's the loss of appetite is there, and then persistent nausea, vomiting, diarrhea, malaise. If these are persisting, that's led to the loss of weight, nutritional status of the patient is derailed here, and then loss of subcutaneous fat, muscle wasting, edema, ascites present. They suggest the also an important tool for the assessment of the nutritional status. So here you can see the one of the diagram I have taken from a book. Okay, so usually that start with the assessment of the nutritional start with the clinical examination of the patient. Like it is examined with the skin, nail, hair, as we have read in the books in the medicine. That like you find the easy bruising of a perifollicular hemorrhage. There is a particularly this is characterized by the vitamin C deficiency. Then flanky point of the lower extremities, that's the zinc, basically zinc, which is wrongly ZINC, zinc. Then coarse skin, popular keratitis, goosebump, that's goosebump, vitamin A deficiency. Then peripheral edema is there, protein deficiency is there. If you examine the eye, after examining the skin, the eye examination is important in physical examination. So conjunctival pallor is there, anemia is certainly to find the like bitot spot, vitamin A deficiency, then ophthalmoplegia, then vitamin thiamine deficiency. Okay, so these are the basically clinical examination findings, so that at least we should reach a conclusion that patient had this sort of the deficiency of the vitamins and protein. Okay, so evaluation of the nutritional status. Here is the assessment of the nutritional status, like then the evaluation of the nutritional status. So properly evaluation start with the physical examination as we did in the from the skin to head to the toes. Okay, so physical examination start with up to the head to the toes, include every part of the body. Okay, from the skin, hair, and eyes, then all the truncal examination, then back examination. So complete physical examination is important to evaluate the nutritional status of an individual. Then general appearance has to be looked for if they initiated a pathetic look. Important assessment of the body fat store. Body fat store basically how it is assessed by skin fold examination over the bicep, tricep, and subscapular region. So they are basically three sites when find the we assess the body fold store by the skin fold examination. We pinch the skin over there, we pull the skin, and if pulling is there, there is really the depletion of the subcutaneous fat is there. So better examination is really done over three sides, basically the bicep, tricep, and subscapular. The assessment of the protein store. Body protein assessment is very important when we evaluate the nutritional structure of the patient. Then it is basically measure the circumference of the muscle belly of the bicep, tricep, supra, and infraspinatus. So protein store, protein nutritional status of the patient regarding to the protein content of the body. It's better to measure the circumference of the bicep, tricep, supra, and infraspinatus muscles. Then assessment of the metabolic stress is basically done by the indirect calorimetry test. Then body temperature, then WBC count, okay, pulse positive blood culture, yes. And also the micro abscesses or any abscess is there, not the abscess is there. So basically assessment of the metabolic stress is important to know the metabolic conditions which can be associated with the various parameters. Okay, like indirect calorimetry test is there, temperature, body temperature monitoring, which is done. WBC count is important, pulse positive blood culture, then abscess, if there are any abscesses formation is there, that's important factor for the metabolic stress. Okay, uh, basically then physiological function. Uh, Physiological function has to be evaluation of the physiological function is by the poor wound healing, early fatigability, grip strength, respiratory muscle function test. So physiological function of the body is basically done by the poor wound healing. If there poor wound healing, then easy fatigability. Then you ask the patient to hold the grip, and if the grip strength is lower side, the physiological give the at least some sort of knowledge about the physiological function. Then respiratory muscle pulmonary function test is important. So all these factors are basically important. So basically, in pre-operative period, the pre-operative risk assessment and optimization of organ dysfunction. Uh, Basically, this has to be counseling is very important. Patient education in the form of patient education. Then uh, rehabilitation period, where you find the pre-rehabilitation period is called the pre-operative period. This is basically where rehabilitate the patient regarding the nutritional deficiency, regarding the improving the strength of the patient, of, uh, then improving the uh, uh, body body physiology to cope up with the stress, and then also important factors to making the patient uh, in the normalized condition so that the stress has to be uh, uh, stress to minimize the stress. So apart from it, the patient education and pre-rehabilitation, we should also having the some advice to the patient, like we should abstain from the any sort of addiction, like in the form of alcohol abuse or smoking, all these things, because this increases the post-operative combination. Then routine examination is very important, as we did in the physical examination. Then there is an important fasting guideline. You should not ask the patient to remain fast in a day before the surgery or for a longer duration. Okay, so there's modern, there's a recent guidelines regarding the uh, how to make the patient pre-operative period in fasting state. There are important guidelines so that patient important nutritional conditions should be maintained to optimize the patient for surgery. Okay, then various uh, also there for this the important role in the physician. The physician role is very important over here. Okay, so identify any nutritional deficiency. Then after that examination portion is over, we find by the lab test or imaging, but this is our not non-specific uh, because the physical examination, physical figure is very important to know the nutritional status. But they add in the our certainly our diagnosis regarding the nutritional status, whether patient is malnourished or undernourished. So it is non-specific but indicate the degree of illness, because it indicates degree rather than the strict marker of the nutrition. Okay, so what are these? The like albumin and pre-albumin. Certainly, when we are planning for the any surgery, okay, this is the important factor. We always look for albumin or pre-albumin. Uh, so basically, this indicates the degree of illness rather than these are not the strict marker of the nutrition, but they are certainly important factor for evaluation, the evaluation of the patient nutritional nutrition and ultimately the outcome. So albumin or pre-albumin, then transferrin level vary with nutrition and body response to inflammation. Okay, transferrin level, this vary with the nutrition and body response to inflammation. Then LFT, the hepatic function test, secondary to capillary leak of enzyme. Then LFT is very important, also important factor for the nutritional assessment. Then C-reactive protein increases on the higher side. There is certain sort of depletion is there. Then WBC and blood sugar level is also important factor. So all these are routine assessment which usually we did in the pre-operative period for assessment or evaluation of the patient nutritional status and the fitness regarding the surgery. That's very important. Okay. Then any specific area, imaging of any specific area, like muscle group is measured by the CT ultrasonography, or certainly if you know this muscle specific muscle uh, compartment is involved, muscular compartment involved, and if specific site is involved, which can do the imaging also, like in the form of USG or uh, uh, computed tomography, like CT, a particular part. Okay. So basically, nutritional requirement of the protein requirement are uh, uh, is basically there are certain formula which are being designed for the to calculation of the energy requirement. Okay, and this is significance, having significance where the patient in the high intensity units or high dependency units. So this is the basically the Harris Benedict equation. You should know the B is equal for the Basel as the expenditure, W stands for the weight in kg, H for height in centimeter, age in year. So basically the nutritional experts basically uses this type of the calculation to design the adequate nutritional support which are to be given in the post-operative period, like in the form of total parental nutrition, okay, or intravenous nutrition, which has to be given in the post. So basically, this formula is for them. Also, the nutritional status also nutritional status is being evaluated depending on the BMI. Okay, so if the BMI is basically calculated on the formula, you should know the weight in kg upon height in meter square. Weight in kg upon height. Okay, so basically you should know that this is important uh, parameter to know the outcome. Here we used to calculate in every patient, BMI is calculated. So at least you should know the BMI where the various is divided into various categories. Okay, there. So if it is BMI is less than 15, we should actually give the calorie intake or daily energy intake of the patient to be maintained up to the 35 to 40 kilocalorie per kg per day. Likewise, if the BMI is 15 to 19, it has to be given between the 30 to 35. Okay, if it is between the 20 to 25 BMI is there, it should be given the patient daily requirement is 20 to 25 kilocalorie per kg per day. If 26 to 29, this is between the 15 to 17. Likewise, if the BMI increases, the daily caloric requirement is decreases. Okay, so we should at least you should know your BMI, and by this chart you can calculate your daily calorie requirement, and so that you should not uh, uh, you should not undergo any sort of overnutrition or malnutrition category. Okay, so that's the important parameters BMI calculation. So I'm again repeating how it is calculated. Weight in kg upon height. So weight is always, you should know that weight is always on higher side. Okay, in kg if you calculate, and height is in meter is lower side. So it's if we divide the higher from lower, you will obviously get this sort of parameters BMI. So this is easy to remember. Okay, so because if weight could not be a 2. Okay, so the height could be in a 2 meter, but weight could not be in a 2 kg. Okay, so that's easy to remember because always student used to forget it. Okay, so to remember it, weight in kg upon height in meter square. Okay, because height, which is often confusing, it is sometimes it is student used to confuse the centimeter square. It is not. It is the meter square which is important. Okay. So protein for ICU patients is slight higher side, 1.5 gram per kg of the body weight. Okay, and for the normal for ward patient, it is up to 1 to 1.5 kg of the normal patient. Okay. Uh, for weight patient, base requirement estimated lean weight. So estimated lean weight is 100 pounds upon 5 upon per 100 pounds per inch above 5 feet. Okay. Then fluid and electrolytes has to be calculated accordingly and based on the daily lab data and weight. And then vitamin only to meet the requirement, daily requirement dietary allowances, because these are not important, very important parameters, but it has to be, if it gives a daily requirement in the form of normal diet, we can provide the adequate amount of the vitamin. But certainly the protein requirement is very important, and apart from it, the fluid and electrolyte monitoring is very important. Okay. So nutritional support basically is given to the patient who has the past medical history, or past medical history regarding the any major surgical procedure or the medical illnesses. The involuntary loss is there. If the involuntary loss, if the blood loss is more than 500 ml, weight BMI is less than 18.5, serum albumin is less than 3, or transferrin level is transferrin less than 200 mg per day. The patient is allowed to try severe burn, trauma, sepsis, pancreatitis patient in a chronic medical illnesses, or the pancreatitis condition where the severe catabolic phase, or if the patient is NPO for 7 days, is the large bowel surgeries, in the major GI surgeries, where it's fine, we used to keep the patient. So nutritional support, basically these are the categories of the groups of the patient or medical condition where patient suffering from the medical condition, where we have to provide the nutritional support to them. Okay. So in the next class we will discuss. So should we stop here? Hello. Hello.
Yes,
So
sir.
should we continue or should we stop here?
No, sir, no, sir. There, we have class.
Huh? Please speak loudly. Any one of you, please. What you want? You want to me to continue or should we stop here and discuss in the next class?
Sir, stop, sir.
Okay. So you full board. Hello.
Yes, sir.
Okay. So rest of the things we'll discuss in the next class. Are you feeling bored?
Sir, not pulling board, sir. We have, sir, another class, sir.
What is your name, dear?
Sir, Gyan Prakash.
Gyan Prakash. Okay, which class? You are
New
having the
class
next
from
class.
sir, 2
Which
o'clock,
class
sir.
taken, huh?
2 o'clock, sir, class.
Which one?
Sir, from from 2 o'clock, sir.
From 2 o'clock. Who is
Yes,
going to take your class?
sir. Gynae, sir.
Gynae. Gynae who is the teacher?
सर ये तो याद नहीं है सर, देखना पड़ेगा.
अच्छा. और तुम लोग अभी उधर घर पे कैसा उधर एंजॉय कर रहे हो, पढ़ाई वढ़ाई कर रहे हो उधर?
सर थोड़ा बहुत हो पा रही है सर.
हाँ. अभी तुम्हारे बीचू में क्या इधर आने का क्या है?
सर अभी तो सर कुछ सर नोटिस निकला ही नहीं, बल्कि सर 16 बैच का नोटिस आया था.
ओके. चलो, okay, take care, but you must read, okay, because
Yes,
certainly this COVID is almost vanishing your clinical acumen, but at least what I know. But if you with not theoretically sound, you will lose everything. Okay, so better to
yes,
study what I have taught you with the surgical nutrition in the. So must read it. Okay, all of you must read it. And one more thing, there I have the important data regarding your attendance. Okay, this shows that only few people, because it gives you the time when you join and when you leave. Okay, so basically this data is going to the director office. Okay, so if you are not present in class for more than 45 minutes, you will be marked absent for the whole of the period. So better to, if what if there is a certainly there is no problem in the network, but at least you should present in the class. Okay, you should present, you should listen. If you have any query, you can ask me the question, but At least I know that you people don't, you are very smart. Okay, so for smarter people, it's better to uh, keep yourself updated. Okay,